All right, let's jump right in with the big question, the one that really gets to the core of what we do in critical care. What is the single most important cause of impaired gas exchange in the ICU? Just let that sit in the back of your mind, because we're going to build up to the answer step by step, right from the very beginning.
So, what we're doing here is a deep dive into impaired gas exchange in the critically ill, but we're going to tackle it from a purely physiological angle. Think of this as a super high-yield review. It's perfect if you're gearing up for your anesthesia exams, or honestly, if you just want to make these core concepts stick. We're going to connect all the dots, from the principles right to the bedside.
Here's our game plan. We'll kick things off with how oxygen normally gets around the body. Then we'll get into the weeds of shunt versus dead space. After that, we'll reveal the main culprit we're all fighting against, and we'll wrap up with the management strategies that are actually proven to work. Let's do it.
Okay, first things first, we have to set a baseline. Before we can even begin to understand what's going wrong with our sickest patients, we need to have a rock-solid grip on the normal process. You know, how does a molecule of oxygen get from the air out there all the way down to the mitochondria where the magic happens?
Let's lock in two definitions right away because these are absolute classic exam fodder. First, hypoxemia. That's a low partial pressure of oxygen, the PaO₂ you see on your blood gas, in the blood. Then you have hypoxia, which is low oxygen in the tissues themselves. They're related, for sure, but they're not the same thing. For today, we're really zoning in on the causes of hypoxemia.
And that brings us to this beautiful concept called the oxygen cascade. Just look at this diagram. The partial pressure of oxygen, the PaO₂, takes a hit at every single step of its journey. It starts off at around 21 kilopascals in the air we breathe, and by the time it gets to the mitochondria, it's less than 1. That's a massive drop, right? And it shows you that every step in this chain is a potential point of failure.
Now let's think about how gravity plays a role in a healthy, upright person. It's pretty intuitive that both ventilation, the V for airflow, and perfusion, the Q for blood flow, are going to be greatest at the bottom of the lungs. Gravity just pulls everything down. But here's the kicker. They don't change at the same rate. Blood flow, the Q, drops off way more dramatically as you go up to the top of the lung. So the ratio of V to Q is actually highest at the top and lowest at the bottom. And that, my friends, is the essence of V/Q matching.
This leads us right into the classic concept of the West zones. This model is all about the battle between three different pressures: the pressure in your alveoli, in your arteries, and in your veins. Up at the top in zone 1, the alveolar pressure can actually be high enough to squash the blood vessels flat. Down at the bottom in zone 3, blood pressure wins, so flow is constant. The most important thing to remember is that these are physiological zones, not fixed anatomical ones. They can change in a heartbeat with things like low cardiac output or when we put a patient on a ventilator.
All right, so we've got the ideal scenario down. Now let's flip the coin and look at the two main ways this whole system can break down. We're talking about shunt and dead space, the two faces of VQ mismatch. Getting this distinction crystal clear is absolutely essential. Okay. This slide, you're going to want to screenshot this one. It's a classic exam setup. On the left, we have shunt, which is a low VQ problem. Think of it this way. Blood is flowing, but it's bypassing any useful ventilation. So deoxygenated blood just cruises right past the lungs without picking up oxygen. This is a major cause of hypoxemia. And here's the key. If it's a true shunt, where ventilation is 0, you can crank the oxygen up to 100% and it just won't help. Now on the right, we have dead space. That's a high VQ problem. Here, you're beautifully ventilating lung tissue that has no blood flowing to it. It's a wasted effort. This messes up your CO2 elimination, causing your PaCO₂ to climb. So what's the bottom line in the ICU? Is the main enemy shunt, or is it dead space? It's time to answer that question we started with.
And here it is. VQ mismatch is, without a doubt, the most important mechanism of impaired gas exchange we see. The truth is, in the real world, diseases like ARDS or pneumonia don't create these perfect pure shunts or pure dead spaces. What they actually create is a whole spectrum of VQ ratios all over the lungs, a phenomenon we call VQ scatter. It's messy.
So where do we see this low VQ, this shunt physiology, really dominating? While the intrapulmonary causes are by far the most common things we deal with in the ICU, we're talking ARDS, pneumonia, atelectasis, pulmonary edema, basically anything that fills up or collapses the alveoli so air can't get in.
And what about the other side of the coin? High VQ, or dead space. A massive PE is the textbook example everyone thinks of, right? Blocked blood flow. But look at the other causes here. Low cardiac output and positive pressure ventilation. I mean, how common are those in the ICU? They both work by increasing that West Zone 1 physiology, creating alveoli that get air but no blood flow. This link between your patient's hemodynamics and their respiratory status is just critical.
Now, this is an absolute game changer for understanding what's happening to your patient. Let's walk through these two pictures. In both scenarios, the patient has a 50% shunt. On the left, their mixed venous saturation, the SpO₂, which is the oxygen level in the blood coming back to the lungs, is a healthy 75%. That shunted blood mixes with the good, oxygenated blood, and you end up with a final arterial saturation of 87.5%. Not great, but okay. Now look at the picture on the right. The patient's cardiac output is dropped, and their SpO₂ is now only 50%. When that super deoxygenated blood gets shunted and mixes in, it drags the final arterial saturation all the way down to 75%. The take-home message is huge. A low cardiac output makes the hypoxemia from a shunt so much worse.
Oh, okay, that's a ton of physiology. But what do we actually do about it? Let's move from the textbook to the bedside and talk about evidence-based management. How do we take this understanding and use it to help our patients? The absolute foundation of modern respiratory care is lung protective ventilation. The whole point is to support the patient without causing more damage. Step 1. Low tidal volumes, always based on ideal body weight. Step 2. Carefully titrate your PEEP to keep the alveoli propped open. And Step 3. Keep a close eye on your plateau pressure and keep it under 30 to avoid overstretching those delicate lung units. And speaking of PEEP, what's the bare minimum? Well, when we're just walking around breathing, we have a closed glottis that gives us our own natural physiological PEEP of around 5 centimeters of water. The second we intubate someone, we take that away. So a PEEP of at least 5 should be applied to pretty much every single ventilated patient, just to get them back to their normal baseline and prevent the airways from collapsing.
So what do you do when lung protective ventilation just isn't cutting it? For severe ARDS, we have an incredibly powerful tool, prone positioning. And the physiology behind it is it's beautiful. When you flip the patient over, you recruit all those collapsed lung regions in the back, where the blood flow is still greatest. You literally take the weight of the heart and the abdomen off the lungs. It helps drain secretions. It's a direct physical attack on VQ mismatch.
And this isn't just some clever idea, the evidence is rock solid. You absolutely have to know the landmark pros of a trial. It showed a clear, significant mortality benefit for proning patients with severe ARDS for at least 16 hours a day. This trial completely changed our practice around the world.
Now, what about the idea of giving a big blast of pressure to try and pop open all that collapsed lung, what we call a recruitment maneuver? It's tempting, right? But, as the source article for this explainer points out, we have to be really careful. Squeezing the chest with that much pressure can tank a patient's blood pressure, especially if they're already a bit dry.
In fact, we have some very strong evidence telling us to pump the brakes on this aggressive approach. The ART investigators trial is another one you've got to know for your exams. It found that routinely using these high-pressure recruitment maneuvers and then sticking the patient on a high PEEP was actually associated with increased mortality. That tells us that a one-size-fits-all aggressive strategy can do more harm than good.
Okay, let's boil this all down. What are the must-know take-home points? Number 1, VQ mismatch is the king. It's the primary cause of bad gas exchange in the ICU. Number 2, you have to think about the underlying problem. Are you dealing with shunt, dead space, or a bit of both? Number 3, lung protective ventilation is your foundation, non-negotiable. And number 4, for the sickest ARDS patients, interventions like proning aren't just a good idea, they are backed by powerful, mortality-reducing evidence.
So I'll leave you with a clinical challenge to think about. You've got a patient with ARDS. Their hypoxemia is getting worse, even though you've got them on perfect lung protective settings. Based on everything we just talked about, what's your next assessment and what's your next move? Everything we've covered today was based on an absolutely fantastic review article called Causes and Management of Impaired Gas Exchange in Critically Ill Patients. It was published in BJ Education in 2024. I seriously recommend you go and read it for an even deeper dive. Thanks so much for tuning in.